Good evening and welcome to San Antonio Regional Hospital's Cardiovascular Community Lecture Series. I'm Allison Lejean, a registered nurse and director of cardiac services, and it's my pleasure to welcome you here this evening. Tonight, our lecture is on cardiothoracic surgery, and we're fortunate enough to have three of our cardiothoracic surgeons here with us this evening. Before we begin the lecture, a couple of housekeeping items I wanted to go over. If you have a question, please utilize the Q&A section and we'll do our best to answer as many questions as possible at the end of the lecture. If you have a question that's a bit more personal in nature, please feel free to email me. My email will be provided at the end of this lecture. It is now my pleasure to introduce Dr. Nan Wang. Dr. Wang is the medical director for cardiothoracic surgery at San Antonio Regional Hospital. For greater than 25 years, his focus has been on complex heart disease surgery. His particular interests are mitral valve repair, aortic root replacement with valve-sparing aortic root reconstruction, aortic aneurysm and dissection repair, thoracic endovascular aneurysm repair, and off-pump coronary artery bypass grafting. Dr. Wang attended Loma Linda University Medical Center School of Medicine for medical school. He also completed his cardiac surgery residency at Loma Linda University. He completed an additional year of fellowship at the Cleveland Clinic Foundation, and his training at Cleveland Clinic focused on mitral valve repair, heart transplantation, and ventricular assist device surgery. It is Dr. Wang's philosophy to embrace the concept of synergy and providing the best care for each of his patients. Each member of the team must work together for the greater good of the patient. Dr. Wang is married to his wife, Sandy, and he enjoys astrophotography, sailing, and traveling around the world. Please join me in welcoming Dr. Wang.
Thank you, Allison. Allison's our cardiac service line director. I'm also very grateful for our marketing team here under the direction of Kathy Redmond. So tonight we're going to focus on the surgical part of heart disease. As you know, cardiac surgery, or you may or may not know, is a team sport. I'm very proud to introduce our team of cardiac surgeons here at San Antonio Regional Hospital, Dr. Lee, Dr. Bansal, and myself. We'll take it from here. Go ahead. I'll start with the discussion on the aortic aneurysm and how it is being done at San Antonio Regional Hospital. What is an aortic aneurysm? Let's start with the aorta. The aorta is this big vascular structure that starts at the heart and ends in the abdominal region, splitting into the other vessels going to the leg. This is like the Highway 10. Aneurysm is a condition where the aorta begin to enlarge. It forms a bulging enlargement in these regions of the vessels. The two most common regions are at the ascending aorta, just above the heart, and in the abdominal aorta, just below the kidneys. Tonight, we're going to focus primarily on the aneurysm that is in the thoracic region, right next to the heart. Oftentimes, the first question patient will ask me would be, well, do I really need to have my chest open? What about the technology of putting a graft inside the vessel without opening your chest? And the answer is yes. For a big portion of the aorta, you don't have to have an open surgery. This is what we call a TVAR endograft, where the graft is put inside the aorta without having the chest open. The same type of thing is being done to the abdominal aorta, but unfortunately, for the ascending aorta and the arch aorta, you still need to have open heart surgery because these very vital vessels are in very critical regions where just applying a tube into these areas will compromise the function of the coronaries, the aortic valve, also the blood vessel to the brain. So this is the ascending thoracic aortic aneurysm. And probably the most common open surgery that's done on the aorta today. At San Antonio Regional Hospital, we do provide this service for our entire primary service line. This is the most common open aortic aneurysm surgery. This is a condition where the aorta above the heart balloons out. Why is important? Why is aortic aneurysm important? I think many of you would know John Ritter. If you're so as I am, you would know that he's the star of Three's the Company. But his contribution, unfortunately, to the medical world is upon his death. He developed aortic dissection on the set. Because it was such a event that's witnessed by so many people. He's a well-known star is a household name to many people. His condition become very well known to all to the community, and what he died of is a aortic dissection. When the aorta balloons out in this region, the wall becomes really thin. Because as the wall becomes thin, it's prone to break. So the layers of the aorta breaks will be the inside layer. We call this the intima. When blood shoots out of the heart, it acts as a knife and cuts right into this layer. And when that happens, this layer splits. When the aorta is really thin and tight, this layer tends to split with more ease. Well, just imagine this aorta now is broken, I would say, and the size of the aorta expands further. This layer gets thinner. You can see how dangerous this situation would be if it happens. Unfortunately, we see quite a few patients every month coming to the emergency room with this condition. The best way to take care of this condition is before it happens. The risk of the operation will be substantially lower if we can detect this aneurysm way ahead of time. Because of John Ritter and his wife, now the medical community picks up on aortic aneurysm more readily as well. It's almost unheard of if you come to the emergency room with a chest pain and not have a CT scan to demonstrate, to be sure that you don't have this condition. Who are the people who get aortic aneurysm? I think most of us know that this President Abraham Lincoln, he's suspected to have what we call the Marfan syndrome. Marfan syndrome are lengthy individuals. They have long hands, long spidery fingers and toes. Sometimes they have very flexible joints. They have the thoracic cavity is sometimes deformed with a sternum that's somewhat crooked, very long span of their arms. These are features of connective tissue abnormalities, but the biggest problem that they have is an aneurysm inside the chest. As many of you know, the aorta here is an elastic and connective tissue that constitute the wall of this vessel. Unfortunately, with this connective tissue syndrome and others like it, the wall becomes the elasticity of the wall is not normal. It expands more readily. And as a result, it becomes a large aneurysm. This is the most common cause of what we would consider degenerative type of aneurysm. The other condition that is very common is what we call a bicuspid valve. As you can see, this aortic valve has two cups. The two of the cups are fused. Unfortunately, on these patients, there is associated connective tissue abnormalities as well. Many of these patients with bicuspid aortic valve have what we call a large aorta, precisely the same kind of reason as a result of connective tissue abnormalities. So what kind of symptoms and signs do you have when something bad happens? If the aorta dissects, pain, this is the worst pain you might experience. There are people where the symptoms are actually quite minimal, and they can present with many other symptoms and signs. The worst is shock. If the blood around the aorta goes into the pericardial space, that means the space around the heart, your heart will have difficulty pumping. You'll be in shock. Other patients, the section chokes off the big vessels going to the brain, chokes off the vessel going to the heart. It can even chokes off the vessel going to the legs, the belly, causing malperfusion. So these patients may come in with strokes, heart attacks, and losing leg functions and abdominal pain. The best way to present is an incidental finding. And this is where, because of the frequency of CT scan being performed, we can pick up these abnormalities fairly early. This is a CT scan, and you don't really need a contrast to demonstrate an aneurysm. As you can see, this is a somewhat enlarged aorta already, but this is truly large. It's about this is almost 6 centimeters. CT angiogram, however, is performed to pick up a dissection. If you come in with severe chest pain, there is suspicion that the wall of the aorta has already split. A CT angiogram can demonstrate this split right here. The wall is supposed to be together here. Now you got a channel in between the walls, and that's the reason we call this a dissection. A very important modality is what we call the transesophageal cardiogram. This picks up not only aneurysm, as you can see in this patient, but also the function of the aortic valve. This is a patient with what is one of our patients here at San Antonio Regional Hospital with Marfan syndrome. You can see the aortic root is 6 centimeters. It's huge. It's the normal aorta should be half as much, about 2.8 centimeters, less than 3 centimeters. The valve sits at the base of the aneurysm. Because the aneurysm pulls the valves apart, you have what we call this very severe leak of the aortic valve. There's aortic insufficiency. Blood is going back into the heart after it's being injected into the aorta. So this is a very important modality to establish the diagnosis, as well as to look at the function of the aortic valve. So this is the same patient that we recently created a video of. In the past, this kind of aneurysms are being treated with what we call the Bansal procedure, where you replace this whole structure with a graft and throw away the valves and have a mechanical valve in this region. We are now able to spare the aortic valve, preserve the aortic valve, so you don't have to have a man-made mechanical valve. This is a sizing device that look at the dimension of the leaflets to determine if it's actually working okay. to determine what size graft we need to use to restore its geometry. We then put sutures at the base of this aortic valve. Mind you, this is the big aneurysm, over 6+ centimeters. And this is the aortic valve sitting in the middle of it at the base. We put these sutures in. This will allow us to anchor a device which will remodel the aortic valve. By that I mean the sutures are then passed across this annuloplasty device. Now, this annuloplasty device, what it does is that it forces this deformed aortic valve caused by the aneurysm to be restored to its intended original geometry. So these sutures will then pass across the device. The device is then lowered into the heart. Let's see, is it gonna go? So there he goes. It provides the foundation, as you would like to think of, for the aortic valve, and forces the aortic valve to be restored to its intended geometry, allowing the valve to close again. You see the valves now closing, coming together, and that is the valve sparing type of operation. So instead of throwing away this perfectly fine valve, we're able to preserve it. And then what we do is put a graft and take away this large aneurysm. And this is the final suture lines that is needed to replace the aneurysm with this graft. More work is still needed because there are coronaries that needs to be reimplanted into this graft. So this is a lot of work for this root type of aneurysm. Now, this is another patient. I think in 1 month, we actually did 4 or 5 of these patients. And this patient, you see the valve is gone. This is a patient with bicuspid valve. We couldn't preserve the valve in this situation because that bicuspid valve has already calcified. And when the leaflets are calcified, it won't work. And so unfortunately, we have to remove these leaflets. And now you got a big hole looking into this left ventricular cavity. And then we replace it with a graft that has a valve in it. And that's the typical Bentos operation. So I would say because we do this at such frequency, and oftentimes, you know, my partners and I are a team in doing this kind of procedure, we really have very good results. In elective operation, essentially, we do not, I can't remember the last time we have a mortality. Emergency operation, which is basically related to the patient with aortic dissection, comes in the middle of the night, aorta broken, just like John Ritter. In centers that reports into a registry, the mortality is 20%. 1 out of 5 patients don't make it. And John Ritter didn't make it. At San Antonio here, we are running a mortality perhaps less than 10%, more along 5 to 8%, substantially reduced. But it just highlights how important it is to diagnose these problems ahead of time and not wait for it to become an emergency. And this is the end result where you have a graft in place of the aneurysm. So in conclusion, timely operation is crucial. And intervention of the aneurysm should be done electively with very low mortality. If you pick the time in doing the operation, generally it goes very well. At San Antonio Regional Hospital, we also minimize the risks in elective situation with better heart and brain protection. As you know, sometimes we have to stop the circulation to put the graft in to the head vessels. We hold a record in terms of circulatory arrest. I think, what was our last record? Yeah, I think it's 11 minutes in one account, but 12 minutes is very common. Even dissection takes a little longer, but still is around 15 to 18 minutes. So these are important things that we do to be sure that the outcome is satisfactory. Another reason to operate on these patients before dissection occurs is that there is a curative intent. If you take away the aneurysm, you'll cure in some ways because the aneurysm is gone. Once you have a dissection, though, that entire aorta is broken, and you have to live with a broken aorta. I think this brings me to the end of my talk. Welcome any questions later, and we'll move on to our next speaker.
Thank you so much, Dr. Wang. I really appreciate all that information. It's very useful. It is now my pleasure to introduce Dr. Neeraj Bansal. Dr. Bansal is a cardiothoracic surgeon with the Synergy CT Surgery Group. He specializes in adult cardiac and thoracic surgical disease. His particular clinical interests are structural heart disease, aortic root disease, and adult thoracic pathology. Dr. Bansal attended medical school at the University of Southern California, where he also completed his general surgery training. He finished his cardiothoracic residency training at Loma Linda University. Dr. Bansal believes that treatment of the patient as a whole is what will yield the best patient outcomes and experience. Dr. Bansal is married to his wife, Jessica, and he has 2 children. In his free time, he enjoys spending time with his family, going outside and hiking, and from what everyone tells me, he loves his Peloton as well. So please join me in welcoming Dr. Bansal.
Well, thank you, Allison. That was a very kind introduction, and thank you all for joining us this evening. I'd like to speak a little bit today about coronary artery disease and surgical treatments for coronary artery disease. So coronary artery disease is very common in America. Unfortunately, it is the most common form of heart disease in America. About 18 million Americans suffer from coronary artery disease, and over 800,000 people in the United States have a heart attack each year. Coronary artery disease causes death in over 360,000 people in America in 2019. I'd like to talk briefly about how it happens. First, there's a plaque deposition and some hardening of the heart arteries. Inside of the artery's wall, there develops a fatty streak, which causes an inflammatory response. That then causes a supply-demand mismatch. The heart wants more blood, but blood can't get there because there's a blockage. Eventually, that plaque may rupture and create a thrombosis inside of these very small arteries that leads to a very massive heart attack. A little bit about the anatomy. In general, we have 3 major heart arteries. There's 2 on the left side, and they come from something called the left main coronary artery. They split into 2 different arteries. One is called the left anterior descending coronary artery, and one is the left circumflex coronary artery. On the right side, you have 1 artery that's called the right coronary artery. So in general, we say there are 3 major coronary arteries. These are very small arteries. They're about 1 to 1.5 millimeters in diameter, and they live on top of our hearts. So let's talk about treatment options for coronary artery disease. In general, there are 3 basic treatment options. One is medication and lifestyle changes. The other is percutaneous stenting. And the last is surgical revascularization or coronary artery bypass grafting. In general, there have been multiple studies conducted since the 1980s that all indicate the same basic principles as to which patients should go for what. These are an innumerous number of trials that all of which have happened since the 1980s till now. And all of them basically have the same universal conclusions. Number 1, coronary revascularization using coronary artery bypass grafting or surgery, or PCI or stents are both safe and effective. They both reduce angina symptoms. coronary artery bypass grafting or surgery prolongs life with patients with disease in the left main coronary artery or with multivessel disease. Coronary artery bypass grafting is superior to stenting in patients with diabetes or multivessel disease or in patients with complex coronary anatomy. I'd like to talk briefly about how this operation is conducted. This is about a 4 to 6 hour long operation. It's done under general anesthesia, meaning the patient is completely asleep with a breathing tube. The first step is to harvest the conduit, meaning procure the vessels in order to reroute the blood past the blockages in the heart arteries. Typically, that's done with vein from the leg and an artery from the chest wall. The vein from the leg, we typically harvest using camera and small incision. The next step is to connect the patient's heart to a heart-lung machine. This is called Cardiopulmonary Bypass. This machine helps support the heart and the lungs for us while we're doing our work on the heart. Next, we graft these vessels. What that means is we are going to sew these veins and arteries onto the patient's native heart arteries in order to reroute the blood past where the blockages are. It's similar to if you're on the freeway and it's a 4-lane highway and there's a traffic accident. 3 of the lanes will be shut down, and instead of going slowly in the traffic jam, you get off the freeway, you go on a side street, you go fast, and you get back on the freeway. That's essentially what we do with blood flow to the heart muscle. When we're done, we separate from cardiopulmonary bypass, we leave some drainage tubes in the chest, and we close the chest cavity. Recovery for our patients is probably the most commonly asked question for me when I'm talking to a patient about coronary artery bypass grafting. At San Antonio, we use enhanced recovery pathways, and this is the basic breakdown of what our expectations are for the patient. The day of surgery, our expectation is the patient should have the breathing tube out. The day after surgery, the patient should be out of bed having a meal. The second day after surgery, the patient should be out of the ICU. On the third day, the remaining drainage tube should be removed. And then the fourth day after surgery, patient should be ready to go home. At San Antonio Regional Hospital, we also have special considerations. There have been many studies that show multi-arterial grafting actually helps with the longevity of the patency of these bypass conduits. And frequently, we may use radial arteries or bilateral mammary arteries in order to support the patient appropriately. We also may use off-pump coronary artery bypass grafting in certain select patients where we feel that that is going to be of benefit for them as well. And of course, because we use a heart team approach, oftentimes a hybrid procedure may be required where stenting and bypass surgery might yield the best outcome for the patient. We perform about 200 of these operations a year, and we have achieved a few different accolades through our work. Watson Health has designated us as a top 50 cardiovascular hospital and one of the regional leaders in outcomes for coronary artery bypass grafting. I just want to thank you again for spending some time with us today, and we look forward to having some time to answer questions at the end of the discussion. Thank you.
Thank you so much, Dr. Bansal. That was very, very informative. And our last speaker this evening is Dr. Vincent Lee. Dr. Lee is a cardiothoracic surgeon with Synergy CT surgery. He specializes in both thoracic and cardiac surgery, which includes surgical management of complex coronary artery disease, valvular heart disease, and complex lung disease. He also has specialized training and certification in transcatheter aortic valve replacement. Dr. Lee attended medical school at Howard University School of Medicine in Washington, D.C. He completed his cardiothoracic surgery residency at Loma Linda University. Dr. Lee's medical interests include working with patients with complex heart disease, COPD, lung cancer, and those patients experience heart failure symptoms. Dr. Lee is dedicated to educating patients about their health. Patients appreciate his attention to detail and the care that he provides. He believes in a doctor-patient collaborative approach to care. He loves to see them smile, knowing he is improving their lives. Dr. Lee is married to his wife, Joan, and they have 2 sons. In his free time, he enjoys biking, reading, and karate. Please join me in welcoming Dr. Lee.
Hello, everyone. Thank you for joining us today. Thank you again for that nice introduction, Allison. So let's begin with San Antonio Hospital valve surgery. So we have no disclosures. So what our objectives, hopefully we will try to talk to you a little bit about the history of valve surgery. And I know when patients come, they've done their research and they have ideas about which valves would be best for them. But at San Antonio, we have a collaborative approach with the cardiologist, anesthesiologist, and the surgeon. And most patients are discussed, and then we decide as a group what's best to offer the patient. And each patient may get a different valve because of other medical history or their age or their life expectancy. So we're going to talk about some of the programs at San Antonio, some new programs that are coming, and also will include some background information that is probably not important for this talk, but just to further try to convince you that these decisions are not made lightly. So when we look at the heart in terms of valves, so there's right side valves. The tricuspid is the most important one. And the left side valves, this is the aortic valve, the mitral valve. So when you present to your primary care doctor, your cardiologist, and you may have symptoms of shortness of breath, or you feel short of breath when you exert yourself, you may say, when I go to the mailbox or the trash can, I have to stop and take a breath. You may notice that your legs are swelling. So depending on what the lesion is for the valve, some people may come with a stroke because they may have an infection on the valve. So we have to put your history together and we do our test like an echocardiogram, and then we'll find out what is causing your symptoms. And then we have to decide which valve is going to be best for you, or should we repair the valve? So we believe that if it's a leaky valve, those valves should be repaired first. Use your own tissue that can last much longer than all of the advancements that we've made in terms of prosthetic valves. So we'll talk a little bit about that. On the left, we're going to see pictures of mechanical valves. So the Starr-Edwards valve was the earliest valve. It was used in 1960. And during my training with Dr. Wang, we saw some of these patients with still functioning Starr-Edwards valves. And there was also a tilting disc valve, which is a mechanical valve. And now this is the latest version, two leaflets that are opening and closing. And it has a polycarbonate on the outside. But all of these valves will require some blood thinner to keep the valve functioning. And then we'll also talk some about these newer additions, which are tissue valves, which come from a cow or a pig. The cow valve is a bovine pericardial valve, or the porcine valve, which comes from the actual pig leaflets, are also part of what we can replace your valve with. So Dr. Swinson, from where Dr. Wang did his training in Cleveland Clinic, he studied over 14,000 of the Cleveland Clinic patients, and we have other options that we could use valves from a human, called a cadaver or homograph valve, or the mechanical or tissue valve. All these valves can last a long time, but what has become really important is what age the patient is and if they have to use anticoagulation. So I know a lot of people want to know when should I get a tissue valve, when should I get a mechanical valve? Well, we've come to see that the younger the patient is, that's probably the time when we should consider the mechanical valve. The mechanical valve can last 20, 30 years. If you're like a 25 to like 45-year-old, if you're going to get a valve replacement, this may be a great valve for you because you can have a valve for a lifetime. If we put a tissue valve in a young patient, we've noticed that it doesn't last quite as long. It may only last 8 to 8 years. But in people over 60, they're lasting 10, 12, 15 years. And hopefully I'll show you some research where we've have authors that have studied these valves and shown how long these valves are actually lasting before they need to be removed or something needs to be done about them. So really we need to figure out how active you are. If you're going to do activities like parachuting or riding motorcycles, well, having a mechanical valve may not be the valve for you because there's going to be bleeding issues. Also for young women that are in the childbearing age, being on a blood thinner is not advised in the first trimester. So maybe we would give you a tissue valve initially, but as you get older and we had to replace the valve, then may be a good time to put in the mechanical valve. All right, so here are some trends in aortic valve replacement. So in the late 1990s, we can probably see that most people were getting equally bioprosthetic valves and tissue valves. But then we started to notice a trend that most of our patients were in their mid 60s. We started seeing that these valves were durable, they were functional, and then, you know, people really weren't a big fan of taking Coumadin and getting their blood checked. But so we're going to see around like 2006, probably 80% of people were getting these tissue valves and only 20% were getting mitral valves. So that's the trend. And this also shows us when we have a STS database where we put all the information in for the patients that we do around the country, and we see that this trend continued. So here again in 2006, 20% mechanical, but by here, it's still about the same, maybe a little bit higher for tissue valves. And you may ask, like, you know, well, before I talk about that, there is another valve that's recently come onto the market. It's called the Onyx valve. It is a mechanical valve, and it's some patients have come in asking for this valve because when we thin your blood, it can be much less thinning than it would be for traditional mechanical valve. And this valve is much quieter. So the mechanical valve does make a sound that the patient notices, but this valve does not. So this may be an option for someone that's on the fence. So sometimes when we talk to the patients, we have to make the decision together. Are you someone that's going to take your medicines? Are you going to want to come back to get another valve done? And so we might choose to take this tissue valve. This mechanical valve. And so these are some of the studies that I was talking about. So we've seen authors that have studied like 15-year data on these tissue valves, and you can see over 15 years, probably 70 to 80% of them are still working. There are some studies out to 18 years and even 20 years. So the 20 years are a little bit lower, 50 to 80, but you can see some of these tissue valves are lasting a long time in people over 60. So, and this also, it shows that when we look at the hemodynamics over 17 years, what we start out in terms of what the cardiologist measure in terms of how well the valve is working, is still working after a long period of time. So now to let you know, like, we're slow adopters to new technology. One of the things that really excited us was when we put in valves, when we look at the body surface area, and then we were given this chart to tell us what size valve to put in. But some patients will have a small annulus where the valve goes in. So we would have to make this annulus bigger. And it does add a little bit more risk to the operation. But then we were introduced to valves that this is the traditional valve that we use now, but this is an old design that came back in vogue. We put the pericardium on the outside of the valve, and so in this way the valve could open up wider. So we were very excited. We didn't have to put in a larger valve or enlarge the root. And there's another valve called the trifecta. And so again, it was based on this old valve design. But we learned that after studying these, initially we were excited, 2-year data, 99% of them were still working well. But then about 3 years later, we started noticing that some of these valves were representing and they were torn, and then we had to go and take them out. So we want to be cautious just because there's new valves that we don't just go with the new one. We want to see over time how they perform. And this is another one with the other valve trifecta. So now we were taking these valves out, or now we don't even put them in anymore. So we also have a group of physicians that meet every 5 to 6 years, and it's based on surgeons, cardiologists, anesthesiologists, and we review all the data and we make recommendations. It's like a guideline. So it's not like, you know, we want you to understand that there's a lot of thought that goes behind who gets referred and when, and it's based on like studies. So we get studies from around the world and we put them in a class. Like the best studies are the ones that have class 1 data. It's like multiple randomized trials, level A evidence. And so then we put these studies into different categories and then we make our recommendations. So when we talk about aortic stenosis, this is one of the reasons a lot of people are referred to us. This is like a normal valve. And these are nice soft leaflets that open widely like this. But some people are born with the leaflets that are fused and heavily calcified. It doesn't open well and it doesn't close well. So this valve can leak and it won't open. And so this is one that can become calcified here. And all, like these valves need to be replaced, so we can't repair these. So this was, these are charts from like 2014, but the most recent study was in 2020. And so the indications are pretty much the same. Some of the more important points were, you know, all patients with severe valvular heart disease should be evaluated by a multidisciplinary team, which we are doing. So treatment of severe aortic stenosis with either TAVR, which we'll talk about briefly, or surgical valve should be based on symptoms or reduced pumping of the heart or ejection fraction. And we may consider earlier intervention if it's indicated by exercise testing, if it's a rapid progression, whereas before everything was based on you had to have heart symptoms. So also for TAVRs, the indications are expanding. Initially, it was only done for people that were inoperable, high-risk patients, but we've moved to intermediate risk. And in the last 2 years, we've considered some low-risk patients. But again, this is still new technology, and we're still a little cautious about who we put these valves in. So our philosophy would be to put them in our older patients and to put the surgical valves in the younger patients. And but there's always scenarios of why we may do different things based on the patient's history. So this is like a picture of an open surgery with, this is the aorta, which the valve sits in. And so this is a picture of taking the old valve out. And then we put sutures in to parachute the valve in. And this is the valve inside the aorta. So in this situation, we're able to clean out all of the debris, put the valve in, seat it well, test it, and close it. So, and we can put in a nice size valve, and then in the future, we'll have options with TAVR. So again, going back to some of the history, like this Star Edwards valve was in 1960. This tissue valve came in the 1980s, and then we came with this Edwards valve in 2011. So from that time, we've had at least 3 generations of this valve, and we've also made improvements in the delivery system. So initially, we had to have very large vessels in the groin to put this valve through, because the valve had to be placed into this cannula, and it needed a bigger one to deliver. So now we've gone from 22 French down to 14 French, and also we only started with 2 valve sizes. Now we've expanded it to 4 valve sizes. So now we can treat a wider range of patients. And also the initial valves had higher incidence of stroke or vessel injury trying to deploy this valve. But with the smaller valve, we see less complications. with this valve. So this is like a picture of the valve being deployed inside your native valve. This is called the TAVR valve. And this is what we mean by putting a TAVR inside of a surgical valve. So this is what we're doing now for people that had their tissue valve 15 years ago. Now we would replace it with a TAVR. So again, surgical transcatheter, there's indication for that. We have some patients that we think would do better with surgery. If you have infection of the valve, it should be done open, or aortic insufficiency. If the valve is bicuspid, there are some of these patients that are crossing over to TAVRs. But if we see the patient has a chest deformity, the aorta is calcified, they've had radiation before, or multiple comorbidities, these people would do better with TAVR. So these were some of the older reasons why some people got TAVR versus surgery. We have a scoring system, how sick the patient is. If they're very sick, they should get a TAVR. If they're a little older or very thin and frail, then we don't want them to undergo surgery, we'll give them a TAVR, okay? Also, if you had a previous operation, if you had bypass surgery, coronary bypass surgery, well, then this time may be a good time for you to have the TAVR. So again, if there's aortic regurgitation, Dr. Wang touched on this a little bit, we're gonna try to repair this valve, okay? These are all the recommendations for that. If there's a mitral problem, usually the problems are the subvalvular apparatus. If one of these cords are broken or elongated, then these should be repaired. There's recommendation for that. These are other repair techniques where we resect the part that's broken and we repair it. So all of these we think are the first way to treat regurg, and instead of putting in a mechanical or a tissue valve. Okay, and so one of the newer things that we're working on is something called Mitral Clip. And so with this, this is approached from the groin, it goes across the inside of the heart, and we put a clip on the middle of the valve. A lot of patients come in asking for this, but this has only been used in patients that are not surgical candidates, because we're not really fixing the problem, we're just kind of temporizing it. So, but this technique has reduced hospital admissions for heart failure by like 49% in 2 years. And it's really for primary MR in people that are not good surgical patients, or secondary MR. So in conclusion, hopefully we were able to show you how we make decisions, and there's data behind it, there's history behind it. So TAVR can be used in high risk and inoperable aortic stenosis patients, and some low risk patients that are we deem appropriate. This transcatheter edge-to-edge repair is that Mitral Clip, which is coming soon to San Antonio. And again, the heart team, it's very important in discussing which approach would be best for each patient. Thank you for joining our talk tonight. And we should be open for a discussion soon.
Thank you so much, Dr. Lee. Really appreciate that. And I would like to just take a moment to thank all three of our surgeons for joining us this evening. They've got very busy schedules, and the fact that we were able to get all three of them together at the same time really is very impressive. And that's why we are so grateful to have such an amazing group of surgeons that we work with. So they're just finishing getting set up, and we're going to start our Q&A section, and we do have quite a few questions, so we'll get through as many as we can. One of the first questions is, do you offer surgery without the use of blood products, like for those who are Jehovah's Witness?
Go ahead.
In select patients with pre-medication, trying to boost up the hemoglobin and so on, we have done Jehovah's Witness patients. Most of our operations are done without blood transfusion anyhow. But yes, we have done Jehovah's Witness patients without blood transfusions as a part of their religious beliefs.
Thank you. What should the patient be concerned about in aftercare when a radial artery is used for cabbage?
Yeah.
Sure. Well, one thing that we do is in order to prevent vasospasm, we put them on a slightly different medication regimen, but for the most part, the radial artery is harvested similar to the veins. It's done through, most of the time, done through a camera and a small incision. The lifting and the kind of weightlifting restrictions that we give patients in general for sternal precautions they just apply to the same way. There's not really too much in terms of their differences in terms of their recovery.
Thank you. Do you use the same kind of valve in TAVRs? And what is the difference in longevity of the different types of valves?
Okay. So with the TAVR valve, it's based on the tissue valve that we've discussed in the years of history we have with it. So that valve, the same tissue is used in the TAVR valve, but the difference is now the engineers have found a way to collapse the valve to allow it to go through a small opening and expand. So as surgeons, we're concerned that is there going to be any extra stress that's put on that valve in the storage time or the crimping of the valve and then expanding. So, you know, the engineers they continue to work on improvements in this valve. And the other thing is they've now put a skirt around the valve to prevent leaking from the valve, which when we do it in the surgical OR, we sew the valve in place and there's no leaking. So in terms of longevity, again, it's going to be age driven. If you're over 60, most people would take a tissue valve and they're lasting between 10 to 12, you can count on 10 to 12 years, maybe 15 years. And we're hoping with the TAVR valve, it can last that long, but we're anticipating 7 years. And there are some studies out there where a few people have made it to 10 years, but that data is still being collected and it's ongoing.
Thank you. Can an MRI of the heart pick up determinants for multiple stents?
Could you repeat the question?
Sure, I can. Absolutely. Can an MRI of the heart pick up determinants for multiple stents? In other words, is there something in the MRI that would indicate to you that the patient would need either multiple stents or perhaps surgery?
Truly, the angiogram is the gold standard for kind of determining stents versus surgery. Again, the data bears out that multivessel disease or left main coronary artery disease, especially in diabetic patients or patients with reduced ejection fraction, surgery is going to be the better of the two choices. Obviously, these are patients that are not. We have a phrase. It's not the age. It's the mileage. Some patients are older, and some patients have COPD. They cannot walk, et cetera, et cetera. Maybe those patients won't do very well with surgical revascularization. But again, those patients require a multidisciplinary conversation with the cardiologists and the surgeons, and that's usually how we come to conclusions as to who should get what surgery versus stents.
So I'll try to answer that question a little bit differently. It's kind of interesting that someone would actually ask that question. Cardiac MRI is used to determine if there is viability to the heart muscle. One of the problems with multiple stents is that you keep stenting a vessel which is completely broken, and your muscle begin to die. And so if you have multiple stents, there's a chance some of those muscles may not be viable. And so the cardiac MRI would then pick up those signals for patients that still has viable muscle. Surgery is still a good option for those patients. For MRI, where the signals are poor, then even surgery can help those patients. So that's what the MRI is best used for in terms of determining whether any kind of revascularization will benefit the patient.
Thank you very much. The next question is, does my health history raise any special concerns about complication potentials?
Yeah, they do. But I'll be perfectly honest. most commonly are patients who are getting a bypass surgery. I would say 80% of them have diabetes. Almost all of them have high blood pressure. All of them have dyslipidemia or cholesterol issues. So it's not a matter of what your medical comorbidities are. It's how manageable are they after surgery. And that's, again, it's something that we take pride in our evaluation preoperatively of patients, and whether they are suitable for surgery or whether they would be best served else doing something else.
Thank you. The next question is, what happens when a widowmaker heart attack occurs and what can be done?
I feel like I'm speaking a lot.
Coronary.
So widowmaker is it's an older term. I try not to use it because I think it's a little crass, but people still use it anyhow. It's essentially when the main artery that gives blood to the left side of the heart goes down, and there's a big clot there that prohibits blood going directly to the heart muscle. Now, what can be done about it? There's a phrase that time is muscle. You want to reperfuse the blood back to the muscle as soon as possible. And that's why, again, we do use a multidisciplinary approach here. And typically speaking, PCI is faster at getting the blood to that heart muscle. However, when that's not available, or that's not an option, or the anatomy is not suitable to that, that's when emergency surgery is performed.
If I'm having open heart surgery, how long should I anticipate my surgery will take?
Well, it depends on the procedure, and if it's a combined procedure, it's going to take a little longer. As we mentioned earlier, if you're going to have just coronary bypass surgery, it's probably going to take around 4 to 6 hours. Part of that time is going to be going to be the anesthesiologist needing time to put you to sleep and placing lines. If we have to harvest conduits, meaning veins and arteries, that's going to take a little time. But the real operating part probably takes an hour, 30 minutes to 2 hours. And then we want to make sure that there's no bleeding, there's no arrhythmias, and then we'll close everything up. And so that's where the time goes. But if we're going to add a valve procedure to it, that could add another 30 minutes to an hour. So you probably should anticipate being in the OR 4 to 5 hours.
Very good. Thank you so much. If I have to have surgery, how large will my incision be?
Well, it's about the size of your breastbone. We do try and make it as cosmetic as possible, but in order to achieve the necessary access to your heart, we do need to open the breastbone. So it's a midline incision overlying your chest bone.
After open heart surgery, how long before I can drive, return to work, and start to exercise?
Exercise starts in the hospital. We have physical therapists that work with the patients day after surgery. They're out of bed. And it's not because we're cruel, it's because we know that that's how patients do better. When you go home, patients are walking, and walking is your form of exercise. And our hope is that you're walking about a mile a day. It doesn't have to be all at once, but it should be broken down into 4 or 5 different 10 to 15-minute episodes. Driving, we usually ask patients not to drive for about 6 weeks or so. And that's mainly 2 reasons. One is if you're taking narcotic pain medication, it's like you're driving drunk, so that's not allowed. And the secondary reason is, God forbid you're in a car accident, the airbag is deployed pretty forcefully and it will disrupt the wound healing for your sternum. So about 6 weeks for driving.
Very good. Thank you so much. The next question is, what is the longevity of stents in a patient with coarcation of the aorta?
Coarcation of the aorta is generally treated in a pediatric population. It is not a good idea for coarcation to not be addressed. When they get into adulthood, there could be a lot of different consequences. Occasionally, in the adult population, the coarcation can be treated by the stent, and it's probably the preferred way to approach this kind of problem. because of stenting in this region, we rarely have to do open surgery for these patients anymore. But in general, it should be done in the pediatric population. And they do have, depends on the size of the patient, how long it's going to last. But in general, they do have good long-term longevity.
Very good. What services are available in ER to help me should I need heart surgery?
Well, the main thing is actually accessibility to the cath lab. I mean, the most emergency surgical services provided by us are either coronary and emergencies or aortic dissections. Those are really your two kind of cardiac emergency surgical things. When it comes to heart attacks, the first step is always the angiogram, because that gives us the roadmap. That tells us where we need to put the bypasses, where the blockages are. And the ER and the cardiology team work very closely together to, again, minimizing the time that it takes to get from ER door to basically balloon, we call it, so basically into the cath lab. When it comes to dissection, CAT scanner is really the gold standard for diagnosis. And so immediately when all three of us get the phone call in the middle of the night for aortic dissection, we mobilize the team before we even get out of bed and run into the hospital and take care of it.
Are there things I should do to prepare for surgery, and how much help will I need after I'm discharged?
Vince?
Well, I like to tell patients, and we might all have a different philosophy depending on what surgery you're going to have done. But we definitely want you to stop smoking. That's going to increase your ability to get off the ventilator and to get off oxygen. And we want patients to know that we want them to walk afterwards. So I would say start building up your endurance if you can, but don't overexert yourself. And start thinking about changing, if you're going to have coronary disease, your eating habits, and start making more plant-based choices. So I would, and then also keep us informed if we set a date and it's in the future, but you start having more symptoms, well, you might need to be done sooner. So we might have to bring you into the hospital, or you might have to be optimized before surgery. Was there another part of the question? Was that it? Okay.
And we have, it looks like one more question. If I don't have the surgery, is it likely I will stay the same or get worse?
Which surgery? All the
Whichever one you
above?
recommend.
It's a complicated question. It depends on what the disease process is. Are there alternatives? And this is kind of, I think, the way that we all think about this. We don't take surgery lightly. We know that open heart surgery is a big deal, but we try and make it as routine as possible. And truly, we try and evaluate what's the risks and the benefits, as Dr. Wang says. So that's the main thing that we have to see is what's the benefit of doing nothing versus the benefit of surgery. That's really how we kind of evaluate the patient.
Yeah, hopefully it will help you more than we hurt you.
Well, again, I would like to thank you all for joining us this evening, and thank you so much to our physicians here for joining us. This has been very informative, and we really appreciate you joining us. Our information will be provided at the end if you have additional questions, and we hope to see you all next week. Have a great night. Thank you.
Thank
Thank you.
Thanks.
Mhm.